So that's why this branch of dermatopathology is taken up by you people. I just heard Dr. Shashi Kumar now, who has done his fellowship in dermatopathology. So I always alert my pathology colleagues that they need to learn dermatopathology, and it's slightly difficult compared to the surgical pathology, what we do. Okay. So will you all be with me? I quickly go through certain patterns. Say yes. Your lunch is delayed. Okay, so you have to be here. I don't think any one of you will say, oh, hypoglycemia. Please don't say that. Your hypoglycemia should be for the knowledge. Okay? Yes, basics. What is most difficult of all? We say this is to see what is in front of our eyes. Why? Because what the mind does not know syndrome. Okay, only once we know each other, then I can say, yeah, I have met you, you're so and so. So this is very, very important. And for dermatopathologists, know and understand dermatopathologists. So you are also a dermatopathologist, we are also dermatopathologists. This is the link between the pathologist and the dermatologist. Anybody can take up this speciality. But I told you, it is derm circuit many a times. It's a special subspecialty for you, even for us, and most general pathologists dislike this. We always see skin biopsy slides which are ready kept aside. Only when the patient comes, they are taken up, and because it is not that palatable or delicious. That should not be there. And we have a very good department of dermatology in JJM and SSI and SRC. They do lots of biopsies, and I have to say, Manjunath is good dermatopathologist. I don't give him the diagnosis, I just keep posting all the microscopic pictures, and immediately he tells me what it is. Okay, so that is the idea behind having he or your association having taken up this basics in dermatopathology. I may not be able to give you tell you the diseases where we see, but just pattern analysis. Once you know the pattern, can't you say this is Arrow shirt and this is Louis Philippi, this is Biba and all that? Yes. The moment you look at it, you can. So that is the way we need to learn these patterns. Yes, the objectives, there's so many objectives. I'm dealing only with epidermal changes because 20 minutes I think I'll be able to do justice only to show you the epidermal changes. And very important here is dermatopathologist speaks totally a different language. You take up any chapter or any book on dermatopathology, so there is a special chapter there on glossary of items because the language spoken is different here. So let us define few terms and then recognize them. And ultimately, the main objective of this session, I tell you, is just to inspire you people to learn dermatopathology and become a dermatopathologist. Many of our dermatology PGs do come to our department to see the slides, or the slides are taken there by Dr. Manjunath and Dr. Jagannath Kumar to show them. So the secret to learn dermatopathology is to view microscopic slides with a clinical eye and to view clinical lesions with microscopic eye. This is what exactly Dr. Shashi Kumar said. He said we are at an advantageous position because we see the lesions. Exactly. But as a pathologist, I am at a disadvantageous position because we describe all the gross lesions, whatever biopsies or operated specimens are sent to us, we see them, but here we are not able to see. So the macroscopy is done by you people. So microscope forms one of the basic requirements for learning dermatopathology. And I just follow this pattern classification system. First we need to know by low power, where is the lesion located? Then medium power, what are the morphological patterns? And high power, what are the cell types? So location, by just looking at it, we'll know whether it is, the lesion is located in the epidermis or stratum corneum. Then is it localized, superficial, whatever is melanocytic problem, where exactly in the epidermis, and what are all the changes. Then dermis, then in the dermis where it is located, then subcutis. So this is how it goes. So determine the part of the skin that is primarily involved. So just by looking at the section also, we'll know which part is probably involved. So advantages of using this pattern approach classification system is it's very methodical. So chances of missing a lesion are very less, and it becomes a ritual once we follow methodically observing everything starting from the keratin layer to subcutis. We will not miss anything. So like how daily morning we get up, if you're in the practice of looking at the god's photograph, you see, then you go brush and all that, and then come for breakfast, right? So that is how this is the ritual followed, and after everything is done, it is just with a flash of a second that we can identify the lesions. Okay, so this I won't tell you. It's like a process of research what Dr. Asha was telling you. So hypothesis, then testing. So what are all the requirements for testing our hypothesis? Okay, fundamental principle is recognition and evaluation of changes in various parts of the skin. I'll just go through now. I'll just show you the histology, what you have learned, the basement membrane, then the basal layer. See, they're all standing like pillars, right? The basal layer, they're at right angles to the basement membrane. Then this is the prickle cells or the spinous layer, and this is the granular layer. Then comes the keratin. And what is there in between? We can say in the basal layer, there are certain cells with clear cytoplasm which look like this. These are the melanocytes. So this is just the basic of skin histology which you had learned 5 years back or long ago in your first year MBBS histology classes. See the prickle cells, they're all connected, interconnected by very nice intercellular bridges. These are keratohyalin granules in the granular layer of cells, and this is the keratin which is typically like basket weave in normal conditions. So these are again melanocytes which have very nice dendritic process. Even light microscopy we can see them. Through their dendrites they transfer melanin to the other cells. So look at the melanocytes. Yes. Merkel cells, of course, we need special stain and immunohistochemistry to recognize them. Yes. So shall we start now? Histology is done. I'm sure you can appreciate something here. What is this layer? Am I audible? Are you able to see? But why silent? What is this layer? They're all interconnected by desmosomes, spinous layer. So desmosomes, we say, is one of the markers to identify squamous cells. What is this layer? Keratin, stratum corneum. Yes. What is this? The line which is very nicely highlighted using a special stain, not the routine HND hematoxyliosin. This is PA stain. What is this?
Basement.
Very good. Basement membrane. So this layer is keratin. So this is epidermis. What are these structures which are going down into the dermis? They're the rete ridges, rete pegs or rete ridges. Okay. Is there something here separating the epidermis and the keratin layer interspersed between? Is it looking different?
Yes, ma'am.
It's looking like a pink line. That is stratum lucidum. No, palm and sole. If you take a biopsy from palm and sole or somewhere nearby, you can easily say or identify the site. That is stratum lucidum. Yes, the rete pegs. How is the skin? This is not skin, okay? This is mucous membrane. So mucous membrane lacks granular layer. Yes. So the epidermal changes are due to all this, and we are going to describe or know about, I'm going to describe and you're going to know about the epidermal changes under these headings. Okay, there are 15. Quickly, I just want to show you the pattern. So once you identify the pattern, let it be. These patterns may not help you to exactly tell the diagnosis, but they give a clue to the underlying. They give a clue to diagnose the lesion. So dermo-epidermal junction, I am not going to deal with. These are all the dermal changes. Yes. Orthokeratosis is the normal process of keratinization. Cells start keratinizing from the basal layer to the epidermis in a process, methodical way, only of a granular layer, then we see the keratin. So if keratinization occurs in between, in an abnormal location, we call it as dyskeratosis. So hyperkeratosis, as the terminology says, it is increase in the thickness of keratin, that is hyperkeratosis. This is orthokeratosis. Just remember the basket weave pattern. So there is one type of hyperkeratosis which is involving this pattern also. We say basket weave type of hyperkeratosis. Otherwise, remember basket weave is a normal type of keratinization. Then, when do we say this is hyperkeratosis? It becomes difficult for us sometimes because you take a biopsy, some amount of keratin is lost. You put it in formalin, yes, by the time we take it out for processing, some amount may be lost. But when the keratin, the amount of keratin exceeds 1/3 the thickness of epidermis, we say there is hyperkeratosis. It could be absolute or relative. So absolute is the granular cells also increase, produce more keratin. So relative, probably you can say when the epidermis is atrophic, the keratin may look more. Yes. So this is hyperkeratosis with normal or there could be hypergranulosis. This is with normal granular layer. It is just only one layer. I am not dealing with the conditions. Okay. So this is again hyperkeratosis. But what has happened to the granular layer here? Is it decreased, normal or increased? Increased. You can see them as blue color cells, right? And it's got a different shape also. This is wedge shape. Very classical of lichen planus. Yes. So keratin here, some amount is washed off. But what has happened to the epidermis compared to the thickness you saw previously? It is decreased, right? So, but this may look more. This is relative increase of keratin, hyperkeratosis, relative. So, based on how this increased keratin appears, morphology, normal we said, basket weave. So, other patterns we say it could be compact, laminated, basket weave, follicular or epidermal. Let us just see the pictures of these. So, how is the keratin here? Can you see lines?
Yes.
They are all in layers. So, what type of keratin is this? Laminated. They are in layers. Laminated type of keratin. And what's happened to the granular layer here? It is increased. See, if we take this as normal, it is increased. Now, what has happened to the keratin? All the laminate. So, you see pages in a book. So, if you don't want few pages and if you paste them together using gum, it becomes compact, right? So, all the laminae have come together and this is the compact type of hyperkeratosis. This is normally seen in palm and soles. Then, so what type of keratin is this?
Basket weave.
Basket weave, right? Only the outline of the keratinized cells is seen. The keratin is usually lost. It gets dissolved during processing. So this is basket weave type of hyperkeratosis. We always look carefully for some organisms when this type of hyperkeratosis is there. This is like spaghetti and meatball appearance. Anyone knows what is this organism? Yeah. Pitriasis versicolor. Yes. So keratin is increased now, but where is it? It is plugging the follicular ostia, right? So this is follicular type of hyperkeratosis. All these give clue to the underlying disorder. I'm not dealing with the conditions where they are seen. I'm just showing you the patterns because it's a basic class. And this is epidermolytic type of hyperkeratosis. We say there is degeneration of cells of stratum malpighi, and this looks like, see, blown by a shotgun, empty cells, and then hyperkeratosis. This is epidermolytic type of hyperkeratosis. Now, remember the types of hyperkeratosis? Yes? No?
Yes, ma'am.
Both answers are welcome. Yes, no, because I don't expect everybody, I do expect everybody to say yes. Please don't sleep off. You're all sitting so far. This is some trend of undergraduates also. They don't occupy front benches. Okay. What's abnormal here? In this keratin layer, which we didn't see earlier?
Nuclei.
Nuclei are present, right? How about this nuclei to look at? They're all sleeping. They're all flat. Okay, they're not round oval. They're all flat. So this is retention of the nuclei in the keratin layer. We call this as parakeratosis. If you want to see parakeratosis, just collect some dandruff and then process and see. So they're all scales. Lesions will be scaly when there is parakeratosis. So retention of nuclei in the keratin layer. And again, looking at their morphology, how they're distributed, there are a lot of types. It could be confluent, it could be focal, it could be in columns, it could be alternating. So I've given some examples also where we see such type of parakeratosis. So can you appreciate the nuclei here now? There is hyperkeratosis, looks quite compact, and retention of nuclei. This is diffuse parakeratosis, confluent or diffuse we can say, very characteristic of psoriasis vulgaris. Now, the parakeratotic scales are heaped up one on the other. Can you appreciate? It's not diffuse, it is focal, heaped up. We call this as cornoid lamellae. So cap-like, focal, cap-like. These are all the conditions where we see this. Now, can you appreciate this heaped up parakeratotic scales?
Yes.
This is cornoid lamella. Now, can you see this vertical or vertically arranged parakeratotic scales? So this is papillary projection of the epidermis, which is quite thick and showing atypicality also. So this is vertical massive parakeratosis. Where do we see parakeratosis here? On either side of the follicular ostia.
Shoulder.
This is the follicular ostia, it is on either side. So what can we call this as?
Shoulder.
Shoulder, very good. Shoulder parakeratosis. Yes. So this is a checkerboard pattern where we see horizontally alternating parakeratosis and hyperkeratosis. So it is focal distribution, it is not diffuse. So parakeratosis, no parakeratosis, parakeratosis like that. So this is a checkerboard pattern, and this is granular parakeratosis. So here the stratum corneum is quite massively thickened. There is hyperkeratosis, and these cells slightly appear basophilic. This is granular parakeratosis. Okay, there are lots of conditions associated with parakeratosis. So now, what is this? Fast. Basket type of keratin. Yes, here it is compact. Here it is laminated and blown out. Epidermolytic. This is, can you appreciate the parakeratosis?
Yes.
Yes. Okay. So granular cell changes, increased, decreased. So wherever there is blue, dark blue staining. So here there is hypergranulosis and this is hypogranulosis. Very typical pattern of verruca vulgaris. On the crest we see hypogranulosis. So one rule you should know, parakeratosis is inversely proportional to granular or granular layer is inversely proportional to parakeratosis. Wherever we see parakeratosis, granular layer would be absent. So hypogranulosis, hypergranulosis. Yeah. So hypogranulosis, no? Because there is parakeratosis. Hypergranulosis, wedge-shaped hypergranulosis, classical of lichen planus. So why you need to learn this is there are about 10 slides that you get in the examination. You have to identify. So assessment drives learning. So at least from the examination point of view, you have to learn. So this is hypogranulosis. Yeah. Okay, epidermal changes. When there is epidermal hyperplasia in skin, we say it is acanthosis. I just show you the types of acanthosis. So very nice article by Bhushan Matke and all in your IJDVL 13, I think I have just quoted. You can just go through. And see, this is psoriasiform hyperplasia. Regular elongated ridges. When it becomes chronic, they get fused. And this is the camel foot appearance. So this is typical psoriasiform hyperplasia. This is clock clutching the ball. So lesion is just limited to one dermal papilla. Such a small lesion, it is lichen nitidus. So epidermis is showing hyperplasia around the lesion. So this is irregular hyperplasia. And this is church spire pattern. And certain lesions, at least we can recognize seborrheic type, seborrheic keratosis is one. See, this is church spire pattern. Then this is antler hound pattern. So Manjunath had this case recently, where it was presented also. So Dowling Dego's disease. So where the ridges have proliferated downwards. This is typical molluscum contagiosum, where the epidermis grows within, inside. That's why you see the umbilicated appearance, and the growth is downwards. And this is resembling cut section of a slice of tomato. And this is pseudo-epitheliomatous hyperplasia. We may mistake it for malignancy. Yeah. Epidermal atrophy, when the skin thickness is less than 5 years, we say 5 layers, it is epidermal atrophy. So all these are atrophic epidermis. Spongiosis is edema in the epidermis, intercellular, in between the cells. When there is edema, we call it as spongiosis, and is always associated with inflammatory cells. Based on what type of inflammatory cells are there, we say it is eosinophilic spongiosis or neutrophilic spongiosis. Yeah, this is spongiotic vesicle. This is intracellular edema. You were just listening to the Zank test, and this is ballooning degeneration of the cells. And this is marked edema with giant cells, which you again heard. And this is acantholysis. The spinous layer, you remember the cells were connected. So these connections are lost, and the cells appear round, and all these are lying freely, especially in vesicobullous lesions. We see this acantholytic cells. This is severe acantholysis. You can see an old building where the bricks are just lying without the cement in between. So dilapidated brick wall appearance. And this is extensive spongiosis. Now, so the necrotic cells. See, these cells are appearing round, no nucleus. This is single cell necrosis, we call it as apoptosis. Then the councilman bodies are civetate bodies. One example is just the lichen planus, where we see them. And if they retain the nucleus, we call them as disc keratotic cells. I told you the keratinization starts only when from the granular layer, and the granular keratin, the keratin layer has cells without nucleus. But here, the keratinization has started even before. It's like premature keratinization. They're the disc keratotic cells, especially in Darier's disease. We see this corpus ronds and grains. See, these are the grains, the parakeratotic cells which are lying. So this is hypergranulosis, and the liquefactive degeneration of the basal cells. I showed you the lining the basement membrane, so that would be disrupted. Then we see vacuolization. It may form Max Joseph space or it may form subepidermal bulla also. So these are, this is the Max Joseph space. So extensive. Yes, epidermotropism is the cells, inflammatory cells entering into the epidermis, especially these are the leukemic cells, we can say lymphoma cells. They just move only till the 1/3, lower 1/3 thickness of the cells. Exocytosis is migration of inflammatory cells into the epidermis, usually associated with spongiosis, and the entire epidermis may be involved. So these are Horn's, that is abrupt complete keratinization. This is pseudohorncyst, that is when I showed you the follicular plugging. If in sections it gets entrapped, that becomes pseudohorncyst. Last one, these are aggregates of epithelial cells in the epidermis, which we don't see normally. They're keratinized, we call them as squamous eddies. Just one condition where we see many of them as irritated seborrheic keratosis. And these are nests of melanocytes. They could be seen in nevus or even malignant melanoma. So nests are cell nests, and this is what we keep seeing routinely in many of the viral infections, especially HPV. This is coilocytic change. Clear cell cytoplasm, perinuclear. We see this clear cytoplasm. So I took 5 minutes, I think 2 bells. Doesn't matter, I told Manjunath, and this is a punishment probably for you because he put my session later. Okay, sorry. Thank you all. At least there's a take-home message that you would be able to appreciate, these morphological features, or when you start learning, you say, yeah, I'm familiar with these terminologies. Okay. So thanks once again. Hope you have not slept. I would have tested all of you, but not possible in a short time. So thanks Manjunath for this opportunity, and very happy to see all the new faces, and good luck. God bless you. Do good, be good. Thank you.
I request Dr. Ravi Ratan sir to hand over the memento to Dr. Shashikara P.